Chandrasekhar Chandru from
Go live.
Adi Chinchinagiri.
Okay. Rajendra, we have to start now. Rajendra, YouTube live ಹೋಗ್ತಾ ಇದೆ. You have to start.
Okay.
So we can start then.
Okay. Okay, that's fine. So ಇದನ್ನ ರೆಕಾರ್ಡಿಂಗ್ ಕೊಡ್ತೀರಾ ಇದಕ್ಕೆ?
Yes.
Zoomed.
ಇವ್ರು ಆಗ್ತಾ ಇದ್ದಾರೆ ರೆಕಾರ್ಡಿಂಗ್.
Recording in progress.
Recording started.
Okay.
Thank you. Good morning, everyone. I would like to welcome you all to our GINA webinar session, today's session. My name is Suresh Ramaya. I'm a mental health nurse from Bangalore, currently based in North England, working in NHS as a clinical lead manager for CCG, which is called as a clinical commissioning group. Just I would like to talk about a little bit about our GINA. GINA, Global Indian Nursing Association, is established during the COVID situation. A group of like-minded people together formed this group to enhance the nursing education and to promote evidence-based nursing practice in India. This voluntary digital platform operated from Europe, especially from UK and Ireland. Today, it's very interesting topic. Basic life support, BLS, essential skills. This is really mandatory training, especially in Europe, if I'm talking about, I'm not sure about in India. So every health workers has to complete this training and also up-to-date annual update as well. That is the mandatory in Europe, as far as I'm aware. For BLS, today our speakers, we have Dr. Rakesh Sharma, who has done his PhD, MSN, BSN, instructor for ATCN, AHA-BLS, and ACLS. He also, working as a assistant professor, College of Nursing, All India Institute of Medical Science, Rishikesh, Uttarkand, India. Sir, behalf of GINA, you are welcome you for this session, sir. Thank you.
Thank you. Thank you, sir.
And also we have our own friend who is a GINA member, Rajendra Irani, who is from Karnataka as well, and currently lives in Ireland. Is a clinical nurse manager 1 in accident and emergency, HSC, Ireland. Rajendra, you also welcome to this meeting. Thank you for your presence. And also we have another guest, I would say guest, Thepesam Villahalli, currently who is in India. He also a member of our GINA team. And he also working as a lead nurse in adult allergy immunization, NHS Trust in UK, but currently he is in India. So Swami, Thepesami, I also welcome you for this session.
Thank you, Suresh.
And also there are lots of colleges, nursing schools, nursing colleges, hospitals around the India. So there are many of the students and many of other people also join this session. I would welcome you all for this session. So the next, I will handing over to Dr. Rakesh Sharma to continue with this presentation, sir. Thank you.
Thank you, Mr. Suresh. This basic life support is a very essential skills which every healthcare professional should know, because we never know when a person get collapsed and we can save his or her life either he or she may be in the hospital or road, in market, in any office, anywhere. So this is as it is a very essential, and in India, if many institute has a guidelines or policy that every healthcare worker has to have this training as a mandatory, but many are not. But here we are helping our nursing students and some of the nursing officers who are working across in India. So I think I would like to request Mr. Irani to talk something about this program.
Okay, Mr. Rakesh.
Yeah.
Before you proceed, just we would like to highlight regarding the education service disclaimer. Even though BLS is standardized across the world, but again, we can't interfere with the local policies, procedures, and guidelines of your respective healthcare institution. So just I'll read out this one, and at the end of the day, GINA is not liable for in any way whatever the information you are utilizing from this education service. That is, this is a free education service is provided by the Global Indian Nursing Association. By accessing or by using this service, you agree to bound by the following terms and conditions. That is, the education information presented during this webinar is intended for provide the supplementary knowledge about essential skills in basic life support. And in the best interest of patient safety, we strongly recommend taking training by the authorized American Heart Association trainer for the full benefit. And also please note, kindly follow your local BLS policies, procedures, and guidelines. And the GINA is not liable for utilization of any information presented in this webinar for the patient care. Next slide, please. And the further information is that at the end of this webinar, we have the 20 questions and 15 minutes. You have to be completed in 15 minutes. And the minimum 90% score is required. So whoever will achieve 90% and above, they'll get the certificate, pass certificate, and as well as they'll be given an open offer for the further intensive BLS training as well as the ACLS training. And the quiz link will be posted in the Zoom, in the chat box, as well as in the YouTube chat box. And the candidate, all the candidate has to present from beginning to end to participate in the quiz. And if you have any further questions, you can post it in the chat box in the Zoom as well as in the YouTube. And if you want to discuss directly with the presenter, please raise the hand at the end of the webinar, and we'll give you opportunity for that one. Next slide, please.
Or they can put it in the chat box as well, the question.
Yeah. So I'll hand over to Mr. Rakesh. Thank you.
Yeah, thank you, Mr. Rajendra. So we have some certain objective of this program webinar, that at the end of this training or this live sessions, you all the participants can recognize the sign of a person's requiring CPR, and you are able to perform a high quality CPR and to provide effective ventilations by using barrier devices. So in this training, we are going to cover following modules, which are like adult BLS, AED for adult and children of 8 or above years, and then high performance team or team dynamics, and the last, spatial considerations and spatial situations. We are not going to cover in the sessions are BLS for child, infant BLS, AED for infant and children less than 8 years of age, and lastly, the relief of choking we are not going to cover in this session. So first question is, what is cardiac arrest and what is heart attack? This is a very basic thing which everybody should know, being a healthcare professional. Cardiac arrest is a kind of electrical supply problem in a simple language. So if it occurs when the heart malfunctions and stops beating unexpectedly. There are many reasons for that, which we are not going to discuss here. So simple, there is a problem of electrical supply or electrical impulses. Due to that, heart is unable to beat. And heart attack, where it is in layman language or simple language, it's a plumbing problem. There's a blockage in the blood vessels or coronary arteries. So what happens when there's a blood flow stops, then heart is blocked and patient may get heart attack. So now in this first module of adult BLS, we are going to discuss about the adult chain of survival. 1 rescue adult BLS and 2 persons rescuer adult BLS. So this is a chain of survival where if we are finding a person with a collapse or unresponsive, what we have to do. So first, these are the basic steps, basic chain that we have to follow. So first is to surveillance, prevent, and then treatment of pre-arrest conditions. Means we try to, in the hospital, we have to plan if a patient is having like on risk. So we have to surveillance, we have to monitor their signs and symptoms, and we have to see if the patient may get. So we have to prepare and prevent the cardiac arrest. If it has happened, then we have to activate the local emergency system. We can call as a code blue or whatever in the hospital or institutions they are following. The next step is to give high quality CPR or chest compression and use of rapid defibrillations. Then lastly, use by helpful with a multidisciplinary team approach we have to use and shift the patients to the ICU or cath lab appropriately. So there may be 2 conditions where we may face that patient is out of the hospital or patient got collapse in hospital. So in hospital situation or setting, the same thing what I have discussed in the previous class, that previous session, slide, we have to prevent occurrence of cardiac arrest. If it is happened, we have to activate the emergency system, start chest compression with a high quality CPR, and administer defibrillator, use of defibrillator, and then shift the patient to a cath lab or ICU appropriately. And if the patient is out of the hospital, first step is to activate the emergency system, then chest compression, use of AED, shifting a patient to the nearby healthcare facility, and utilization of resources or like cath lab and ICU or based on patient's condition we have to follow. So next is this pyramid shows like any person, any layman also can learn how to give chest compression, only chest compression, which can save like a larger population. But if a person who got training has the skills of how to give breath and using of team dynamics in a hospital setting can save better way a life of a patient. So now the first step in the BLS sequences is checking the scene safety. Then second is to check the response of a patient. If patient is not responding, then call 108. In India, we are having this, or any local facility, or if your friend is working in any hospital, you can call him or her for the help. Then next step is to look for breathing. The patient is breathing or not, or he is gasping. If gasping, also considered as a no breath. And assess for the pulse. You should assess the pulse not more than 10 seconds. So 5 to 10 seconds within that, you should assess. If you are not finding pulse, next step is to start CPR. If there are some situations, if you find the patient is having normal breath and also there is a pulse, then just monitor the patient and wait for the emergency to or help to come to your place. Second situation, if no normal breath, but there is a pulse, So what you can do here, you can give only breath. So one breath every 5 to 6 seconds, or about 10 to 12 breaths per minute you can deliver to the patients. In the third situation or third scenario, there is no breath or no pulse. So what you have to do? You have to start good quality of CPR, which includes 30 compressions and 2 rescue breaths. And as soon as this AED comes, you can use the AED. The soon it comes, you have to start using of AED. So scene safety. Why it is important to check the scene, and then you have to make the patient in a safe position or safe situation. It is also important, while saving someone's life, we should also save our own life. A patient, if we see a condition where patient is near to the fire, there we cannot go and start CPR, because we may also, our life also will be in a threat. Or if a patient, a car got collapsed, and then between the road a patient is collapsed, you have seen, and in between the road you cannot start the CPR. So what you have to do? You have to bring the patient in a safe area, safe zone, where your life is not in a threat. So scene safety, like the patient is in a water, so you have to take the patient out of water. Maybe electrical wires are there you can't give CPR. So just see, your life is also important than the patient for whom you are planning to start CPR. So next step or second step is to check the response. Now a patient who is it is not 100% that patient got a collapse. You saw on the side of the road one Babaji is lying down. Don't think that patient is in a cardiac arrest. Possibly that he or she is sleeping. So you can't directly jump and start chest compression that I wanted to give CPR. No. Just see the patients, check the response of the patient. So gently tap the shoulders of the patient and ask, are you okay? In your own local language, okay, you can ask, hello Cheta, hello Anna, hello brother, whatever, hello Bhaiya, uncle, whatever you can use in your local language. You can shout, call, and ask them, check the response. Next is, once if the patient is not responding, then you have to activate the emergency system. You can shout for the help. You can call from your mobile, keep your mobile on speakerphone and call 108 or any help services, maybe hospital or anyone. So what you can do, you can dial the number, keep the mobile in a speaker and start CPR procedures or steps as we are teaching. Now, assess the breathing and pulse rate. So how to assess the pulse and breath? Observe the patient chest raise and fall for not more than 10 seconds. This is very important. Why we are again and again I'm telling that not more than 10 seconds, because if you are wasting lots of time to assess the patient, to check their pulse and breath, you are wasting the golden time. You are wasting the patient's golden lifetime. So it should not be more than 10 seconds, averagely 5 to 10 seconds. If there is the condition, there is no breath, only gasping, no pulse. So what you can do, you can start CPR with a 30 compression and 2 rescue breath and use of AED as soon as possible. Second situation, if no normal breath but pulse is present, so you can give only breath, which is 1 breath every 5 to 6 seconds, or about 10 to 12 breaths per minute. This is also important. What is the duration and how many breaths you have to give? So remember, 1 breath every 5 to 6 seconds and or 10 to 12 breaths per minute. Next question is how to check this pulse. Now we have to check the carotid pulse, which is located near to the trachea. So how you can check it? Slide your 2 to 3 fingers into the groove between the trachea and the muscles at the side of neck. You can feel the pulsation. There you can keep your fingers and feel pulse, carotid pulse between 5 to 10 seconds. It should not be more than 10 seconds. So there's a video. You can see how this can be checked.
On both sides of the neck. They're used to assess a pulse when responding to a patient who's unconscious, or to assess a heart rate when a radial pulse is difficult to find. To find the carotid pulse, use 2 or 3 fingers to locate the trachea. The trachea is the tube that runs down the center of the neck. Pull your fingers along the patient's jawline towards yourself, stopping in the groove between the trachea and the muscle on the side of the neck.
So hope you have seen this video to how to locate the pulse.
The carotid artery.
Next, assess the pulse. Feel the carotid pulse for at least 5 seconds, but not more than 10 seconds. If normal breath is there, has pulse, monitor the patient and then wait for the emergency to arrive to help you. If there is no breath, patient is gasping, no pulse, then start CPR with a 30 compression and 2 rescue breath and use AED. This is repeatedly I am giving message that at least this should be by-hearted after this program, that these steps you are following. So check the pulse, what is the duration, there are condition, patient is having breath, no pulse, what you can do? Start CPR. If breath, no pulse, start CPR. If pulse is there, so give rescue breath, that is also important. Now, the techniques of giving chest compression. This is very important to give in the high quality CPR. A good chest compression, which includes a depth of like 5 centimeter, at least 5 centimeter or 5 to 7 centimeter chest compression should be there. Then what should be the rate of this chest compression? It should be 100 to 120 compressions per minute. And press the chest at down at least 5 centimeter with each compression, and then allow the chest to recoil completely. So allowing the chest to recoil will allow the person's lungs to take the normal air, environmental air to inside, inhale. That is based on the techniques of physics. Now, how to place your hand? It is very simple. You just see the patient, expose the patient, and then see nipples, and make an imaginary line between, draw an imaginary line between 2 nipples, and there you can keep your palm of the hands, and both the palm of the hands you can keep at the middle of the line, which is sternum, and start pushing hard and pushing fast appropriately. So here there are critical components of the chest compression. Ensure that victim is on a firm surface. Importance of the chest recoil. Compression rate and depth, which is 100 to 120 chest compressions per minute, and depth is 2 inch or at least 5 centimeter. Next is compression to ventilation ratio. That should be 30 to 2, means 30 chest compression and 2 rescue breath has to be given. And the last, minimize the interruption in the chest compression. The chest compression should be continued. Either help should come or you got tired. So this is the one question. I am alone in the somewhere and I am giving chest compression. How long I should continue this chest compression? You have activated emergency system. People will come for help. But if the place is somewhere isolated where a lot of time is taking to the help to come, so how long you can give until you are comfortable to continue your chest compression? So high quality CPR. This is a video you can see.
The foundation for resuscitation of cardiac arrest patients is high-quality basic life support. It's critical that you successfully perform these skills because effective advanced cardiovascular life support depends on them. These skills help save lives. High-quality CPR maintains blood flow to vital organs, especially the heart and brain. The components of high-quality CPR include adequate compression depth. Remember to push hard, compressing at a depth of at least 2 inches. Make sure you position your body over the patient. Good body position, with the shoulders serving as the fulcrum over the chest, will help you use your own body weight to perform compressions. Consider a step stool if necessary to achieve this position. If the person is not on a firm, flat surface, consider inserting a short board beneath them. Adequate compression rate. It is important to push fast by compressing at a rate of 100 to 120 compressions per minute, allowing complete chest recoil between compressions, minimizing interruptions in compressions. Healthcare providers must minimize interruptions in chest compressions. This includes any pauses to deliver ventilations. When healthcare providers interrupt chest compressions, coronary perfusion pressure decreases dramatically and remains very low until compressions are resumed. It takes several compressions to build enough pressure to achieve an adequate coronary perfusion pressure necessary to get ROSC. And finally, avoiding excessive ventilation. The AHA requires the use of audio-visual feedback and prompt devices during a training practice and testing, and highly recommends use during real emergencies for real-time monitoring of CPR quality. The first skill we'll demonstrate is performing continuous chest compressions for 2 minutes.
So this video has demonstrated the importance and the techniques of chest compression. Now there are technology has come in the BLS. There are some devices which will help us to guide us actually that our compression, chest compressions are good quality or not. So there are devices which can be used when we give chest compression. So we keep these devices between the chest and between our hands. And there are some lighting and there are some verbal or auditory devices also has come in the recently, which are connected with the pads of AED. So that will guide us to that our chest compressions are in a good quality of or not. Now recently there has new techniques in the BLS. There's a machine. I request Mr. Rajendra to tell about these devices.
Thank you, Mr. Rakesh. So this is called as a chest compression system. And one of the main company which is producing is called as Lucas. So we in Europe usually call it as the Lucas. And you can see here on the green part, so its name is the Lucas. So this is the device, automated device. So here there is no role of the compressor, the manual compressor. All the cardiac compression will be done by this machine and accurately. And it has the two mode. One is No, one second, not to play now, please. So
Yeah.
one is there is no advanced airway, then it automatically, there's a one button. If you click that one, it gives the compression 30 and it gives the pause for the 2 breaths. And if there is advanced airway in place, so after every 15 compression, it stops for 2 breaths. So it is very good if you're transferring the patient, especially it's used by the EMT, that's emergency medical team in ambulances, where they're transferring the patient. It's very handy. And also, if you're transferring the patient from one department to the another department, or from one area to the another area, for example, you are giving the cardiac compression and the active ACLS is going on, but you notice something is wrong, and our patient has to go to the cath lab straight away. So from the emergency department to the cath lab, we can use this machine, and during the during the PCA or stenting process also, this can be used. So without wasting any time. So this is one of the best device especially during for the transfer. Can you play video, please?
Horse comes out, back strap goes straight under. Okay, keep going with CPR. Someone's doing manual CPR. Check this thing out. Alright, so all I do is pull it, clip it on. Someone could continue CPR as well. Okay, it goes on, turn it on, get it pretty much center of the chest, get it right there. Hit number 2, and then away you go with CPR. So we're on to CPR, perfect quality CPR given. Let's bring the defib in, get the defib going. While we're on the LifePack devices, we've got the LifePack CR2, so I can now put this on around compressions being given with this great Lucas device. Just jump ahead, drive the seatbelt with the pads, okay? One there, one there, okay? Device fires up, says stand clear. I can pause that device while I give the shot. Lucas, awesome mechanical CPR.
And there's one more video in hospital.
Yeah. So after the chest compression, the next step is to give rescue breaths. Now, giving rescue breath also need some skills. So there are 2 techniques principally we use. First is head to tilt, chin lift, head tilt and chin lift. Why this is required? This technique will help us to make the air entry or the passage of airway of patient in a straightened way. So in the head tilt and chin lift technique, what we do, we keep one hand over the patient's forehead, and then with another hand, we just lift the chin or push the chin. So by which this patient's airway become straightened. But in case if patient is we suspect the patient is having some spinal cord injury, so we avoid that technique and we perform jaw thrust. In jaw thrust, what we do, we hold the mandible and we just lift the chin to the up, as you can see in the video or animation video, how the patient's chin is lifted with a jaw thrust technique. So there's a video, you can see how this head tilt and chin lift technique is utilized.
What we're going to do is the head tilt, chin lift. We place one hand on the forehead and the other hand on the bony part of the chin, and we're going to tilt that back. What that's doing is it's pulling the tongue away from the back of the throat, therefore opening the air for airway. Therefore, we can hear whether they're breathing. So when we put our ear down, we can feel, listen, and see that the person's breathing. It's a very simple method. So to show that in a little bit more detail, we're just going to use this model. What I'm doing is my hand on the forehead and also onto the bony part of the chin. By tilting the head back, you see it's starting to pull that tongue away, and now it's fully away from the back of the throat. So it's quite easy for the air to go in and out, and we can assess whether the person's breathing or not. So you see how simple it is. A simple action like tilting someone's head back and opening the airway can save their life. What we're going to do.
So after this head tilt and chin lift and or jaw thrust technique, now next step is to use of pocket mask. So pocket mask in Western country, all the like healthcare workers, they keep in their pocket or in their kit. In India also we use this in emergency or trauma centers or this ambulance also. So this pocket mask is a small device which can be kept in our even our bags. Whenever we travel, we can keep this small device. So this is a one-way wall, and by which we can give rescue breath to the patient or a victim. So there are techniques. If we are one person giving rescue breath by mouth to mouth, also it is given. So we can keep the narrow part over the nose and broad part over the chin, and we can make a C and E C technique with one hand, and then with the another hand we can lift up the chin of the patient, so that will make the airway entry properly. Now we can if we are having extra resources, we can sit at the head end of the patient, and we can use the jaw thrust maneuver technique also we can use, and then we can give rescue breath to the patient. This is the using of pocket mask. If next is use of Ambu Bag, which I think everybody have seen in the hospital and in the labs. So this provides a positive pressure ventilation to your victims who is not breathing or not able to breathe normally. So bag mask device may be used with or without any oxygen supply also. There is connections which we can connect to the source of oxygen by the cylinder or maybe wall mount. If not attached to the oxygen flow, it provides about natural oxygen which is available 20%, 21% in the environment or room air. So use of bag and mask also need special techniques and skills. If one person is giving breath, then we can use 1C, 1E technique. And if there are two persons, we have extra resources. So one person can hold the mask of the bag, this Ambu bag, and with the one finger and thumb, we can make a C, and with the rest three fingers, including little, we can make E, and we can secure tighten the airway properly. There is no leakage in that. So this is a one person and two persons technique with a CE technique, which is called. Now you can see one video how this person is giving breath to a dummy.
What we're going to look at now is the use of the bag valve mask to ventilate the patient's lungs should they be breathing inadequately. We would always try and use an airway adjunct to enable us to get good ventilations. Typical bag valve mask has a chamber which holds approximately 1200 mils of air. And this is important to remember that when we're ventilating a patient, normal tidal volume is only about 500. So an adequate squeeze of the bag would just be to expel half of the amount of air. And actually, when you are ventilating a patient, try to think about how we breathe normally. We don't suddenly take a gasp. We breathe gently in and exhale slowly. And this we should replicate when we are ventilating our patients' lungs. Failure to ventilate in a similar way to how we breathe would result in the epiglottis potentially closing and diverting air down into the stomach. And when the stomach's full, it will empty and the contents will come up into the patient's mouth, causing us further problems. So always try and replicate the way that we breathe when ventilating a patient. The mask should have an adequate amount of air in so it will form a seal around the patient's face. And a really good technique for achieving a seal, first time, every time, is to hold your finger and thumb in a C shape over the mask, like so, keeping these 3 fingers free. And then this part, the pointy part of the mask, goes over the bridge of the nose and then roll the mask down onto the patient's face, securing it with those 3 fingers over the hard bone of the mandible. Tilt the head back and we should and a normal respiratory rate or ventilatory rate for an adult would be approximately once every 5 or 6 seconds. What we're going to look at.
So in the last video, the gentleman has explained how to give breath by the bag and mask. This is a very simple technique. When we press the bag, we can count 1001 and gently press. So if I'll press gently, I'll call 1001. And for during the deflation, I'll count 1002. Again, I'll press the bag and tell 1003. And again, deflate 1004. So it gives the timing, it makes a rhythmic and gives the proper timing to deliver a breath to a patient. So if I'll tell, like if I'm pressing 1001, gently press 1002, release 1003, press 1004, release. So by this, I have delivered 2 rescue breaths to the victim. Now, this is a picture which has which shows that a person who is giving chest compression and another person is sitting at the head of the end of the patient and giving chest rescue breath. When chest compressions are given, it is not important. Always remember that the bag mask or mask from the face has to be removed. So what happened? In general, when the person is giving chest compression, the air entry and air exit is happening simultaneously from the mouth or from the nose, and the person is taking air or oxygen 21% from the room air by in natural process. Now, next step to use of AED for an adult or a patient child with a 8 or more year age. So I hope that everybody have seen this AED. So what is the name of full form of AED? It is automated external defibrillator. It is a very lightweight machine, a very computerized device which can identify heart rhythm that needs a shock. So AED can deliver a shock that can stop abnormal rhythm, VF or VT, and allows the heart to come to the normal rhythm, to return to as a work function as a normal. So basically what happens when the patient gets heart attack or cardiac arrest, his or her rhythm of heart is desynchronized or stop sometime. So what this AED does, it is a kind of restart our system when our computer or laptop got stuck in our hand. So what we do, we just simply restart. So same way this AED, what it does, it gives the shock to the heart, and during this shock, heart stopped for some time, for few seconds, and restart again and comes to a normal rhythm. So once you get the AED, what you have to do it? What are the steps you have to follow? Because this is also important. Many machines, what they have that once you open the box, it automatically starts switched on. But there are machines, when you open the box, you have to press the power button to start it. So first step in the use of AED is to power on the AED. Second step is to use or attach AED pads, adult pad, to the bare chest. Now, bare chest means the patient over the chest, patient may have hairy chest that has to be cleaned with a razor or blade. In case you don't have blade or razor, but you are having extra pads, AED pad, so these pads are sticky in the nature. So what you can do, you attach these two pads over the hairy chest where you wanted to apply, which is given on the pictures are given on the pads, and gently press and remove very quickly, fastly. So what will happen, this along with the, when you will pull it, the hairs will come out from the chest, and then the second pad or another extra pad, whatever you are having, that you can apply over the chest. So don't touch the patients. Allow once you attach to the these pads to the chest, what they start checking the rhythm. And this AD will give instruction: do not touch the patients, allow AD to analyze the rhythm. So this machine starts analyzing the patient's heart rhythm. Then the AD gives direction what you have to do next. If AD advised to give a shock, then you have to clear a patient, or say all clear patient, and push the button of delivering shock. What happens if you are delivering shock and somebody is touching the patient's body? That person also will get electrical shock. So if you are monitoring or handling the AD, ensure that somebody is not touching the patient's body. If then that person also will get the electric shock. After 5 cycles or 2 minutes of CPR, AED will repeat steps 3 to 5, 3 to 5. So this is about AED. One more thing about the AED. You have to ensure, like sometimes patient is having some implant or pacemaker, so that can be seen by visibly elevated lump. So don't place your these pads over the lump. If patient is having hairy water on the chest, so wipe that water first, and then you place these pads. There's a video about it, you can see, and you will understand better way.
In the event of an emergency, it's important we all understand what to do until medical help arrives, because every second matters.
Zach, are you okay? Zach, can you hear me? Can you hear me? Zach, can you call 911, tell them we have an unconscious male, and report back to me once you're done?
Yes.
Perfect, thank you. Kate, can you go grab the AED from the safe station? Do you know where it is?
Yes.
Bring it back to me once you get it.
Unusual breathing, or gasping, is common during sudden cardiac arrest. This is called agonal breathing. If someone is not breathing normally, you need to begin CPR immediately.
Okay. Stay calm. Check responsiveness. Call for help. Attach defib pads to patient's bare chest. Don't touch patient. Analyze. Shock advised. Press flashing shock button.
Stand clear. All clear? Shocking now.
Shock over. Start CPR. Don't touch patient. Analyze. No shock advised.
He's breathing. Zach, it's okay. Help's on the way.
Okay, everyone's on the way. Okay, come on.
It's okay. Keep breathing. Zach. In the event of an emergency,
So in the last video, you have seen how help has come with the AED and then placement of the two pads over the left side below the nipple and in the right side below the this collarbone. And then after attachment of these two AED pad, machine has given instruction. This machine is analyzing rhythm. Do not touch. Why we have not to touch during the analyzing the rhythm? Because the machine will detect like false rhythm. If I am touching to the patient, then the machine will analyze my rhythm, because it's a matter of electrical impulses or electricity. So simply in simple, do not touch the patient during the analyzing rhythm. And if the patient is required to be given shock, then there is an instruction: give or deliver shock, push a blinking red or orange button. At the time, everybody should be clear away from the patients and then deliver a shock. The next module is of high performance of team. So about the team dynamics, I request Mr. Rajendra to say something and or continue this module.
Thank you, Mr. Rakesh. I would like to share this screen from my side.
I'll stop screen sharing from my side.
Rakesh, can you hear me?
Yeah, I can hear.
There was a question about someone from somebody about. Can you please repeat the position of the pads on the chest, please?
Sure. In the AD machine, there are two pads. One is for right side of the chest and left. One is for the left side. Over these two pads, there is a diagram. By seeing the pad itself, you can understand where to place these two pads. One pad below the right side, below this collarbone, just below the collarbone, and in the left side below the nipple, below the nipple in the left side. And if you can see, if you get an opportunity to see the AED pad, by seeing itself, anybody can understand where to place these pads. I hope I could able to answer the questions which was there. If anything.
There was two more there's two more members who raised their hand. Ashwini Bosle, you are the first one. Do you have any questions?
Yeah.
Swami, that question shall we take later on?
Ashwini?
Swami, shall we call them later on? Just keep
take the questions at the end of the session.
Yes.
Okay.
Yes,
all right.
it's better.
Thank you. Sorry, guys. Yeah.
No problem. Yeah.
Is everybody can see my slide?
Yes.
Yeah.
Thank you. Okay, so the next module is module 7. As we mentioned earlier, we are not going to cover all the modules. We are covering only the selected module because of the time restriction. And if anyone wishes to learn more about BLS and wish to learn all the modules, please let us know. So we'll take into the consideration, but provided they have to secure minimum 90% marks in this quiz. Special considerations. So when you are doing the high quality CPR, so what are the special precautions you need to take? So one, especially if you are using the AED, and already Mr. Rakesh has covered almost all the points. Just I'm going to highlight those points once again briefly. So as soon as you are going to see the patient, when you once check the response, if you determine yes that patient needs this high quality CPR, expose the patient, take up the clothing. That's most important. You can't do the CPR with with a closed chest. We don't know what happened. It may be a severe trauma, or anything might happen, or it may be severe blunt trauma. So you have to expose the patient completely. Take off the cloth, irrespective whether the patient is a male or female. First, expose the patient. Second one, after that one is the hairy chest. So as already Mr. Rakesh told that once you before application of the pad, there are in the AED pack you will be having the razor and the 2 sets of pads. I personally prefer not to use the second set of pad because we don't know in case within 1 hour span, and if you have one more cardiac arrest within the community or within the hospital or even within the locality where you are living, so then you will be run out of the stock. So what I can personally suggest that as soon as you open AED pack, and if you see the razor, high priority should be given to use the razor over the second use of the second pad. So shave the patient chest, then apply the pad for the for effective electrical conductions. Second one is if there is a water, or if you see that patient had a cardiac arrest or patient is collapsed near to the water source, bring the patients to the dry area, drag the patient, you can't lift, drag the patients to the safer zone, then dry the chest either with the tissue paper or with the towel or whatever the cloths you have nearby, just to dry the chest before application of the AED pad. And if there is a pacemaker and you can see the lump, usually it will be on the exactly over the right side, just below the clavicle. If you see that one, or even if you sometimes on the right side, if you see those, the lumpy area, apply the pad just below that one, not over that one. And if there is a transdermal patch, the medication patch, take it off, because what happens is that the medication patch is having the thin metal layer in between. So that metal layer prevents the medications to move in one direction toward the patient's skin, not the medications to come up over the patch. So that metal layer will be there inside the patch, which won't be visible outside. So if you apply the AED pad over that transdermal patch, so the shock conduction won't be the right, or it may damage the skin. Clothing already I mentioned, and the breast tissue. If the patient is a female lady, if the female, and if she collapsed, and if you're doing the CPR on that patient, and if you're applying the AED pad, the right pad, one pad you're applying just below the right clavicle, whereas the second one has to go under the left nipple, under the armpit. So lift the breast tissue, then you apply the pad, not over the breast tissue, because there won't be any sufficient electrical conduction and your shock won't be effective. And the cluttered wire. So when you're applying the AED pads, make sure that no wires goes under the pad. So all the wires should be free and no wires under the pad. So that is no wire between the pad and the skin. And most important, remember to clear. That is, before giving the shock or before analyzing, clear the patient. No one should touch the patient. One is before analyzing, if you touch the patient, the rhythm won't, sometimes AED will recognize your rhythm, or the electric conductions won't be right to recognize it. And before giving the shock, you have to clear the patient. No one should touch the patient to prevent your harm. So here is a few videos regarding the whatever I mentioned now.
Removing the chest. You need to place it.
Okay, I'll go back to the model 6 now regarding the high performance team. Is it audible?
Yes.
Am I audible?
Yes.
Okay.
Yes.
Okay. So high performance team. This is one of the most important thing. In the CPR, in high quality CPR, either BLS or ACLS, there is no I. This is all about we, the teamwork. One person can't save the patient. So we need ideally we need 6 qualified team members to save the patient. So in this whole team, if you see here, we can there's a triangle, then other 3 members. So I'll go through that one, who are all these team members and what is their role. But before I proceed to this one, in your workplace, before you start your shift, you have to allocate, especially if you're working in the emergency department, you should know at the beginning of the shift, you should know who is the team leader. If you get any cardiac arrest patient, how you are going to deal that one. So always you can anticipate cardiac arrest patients when they will come, how to deal with them. So who is the team leader for that shift, 12-hour shift, and who is going to manage the airway, who is going to manage the compression, who is going to manage the monitor. So these all should be pre-planned. We can't anticipate everything, but certain things can be planned at the beginning of the shift. So if I go to shift, I know that every day, every shift, I know it may be day shift or night shift, I know who is the team leader, who is going to manage the airway, who is going to manage the compression, so that when the patient, even when you get the patient, sometimes we'll be having 8 minutes, 10 minutes expected time of arrival. So at that time, we won't be running around. So the moment patient comes, everybody knows their roles and will initiate those roles and will execute the plan of action. So the team role includes, the whole team includes 6 members. So these 6 members can be divided into the 2 groups. One is resuscitation triangle role and another one is the leadership role. So priority is you can see that one, the triangle. This is called as resuscitation triangle. So first includes the compressor. So this compressor will assess the patient, recognize the requirement of the CPR. Then after recognition, that patient needs the CPR. So he or she will initiate the compression. So this person is responsible for giving the 5 cycles of CPR or continuation of the CPR for 2 minutes. Once this complete, and because CPR is very exhausting procedure, especially when you are under pressure, when your adrenals are rushing all over your body, 2 minutes is a long time. So it's easy to get exhausted. So ideally, to maintain the high quality CPR, you need to switch between the compressor and the AED, the person who is monitoring the AED or defibrillator. So you can see here. So this compressor will be giving the 5 cycles of cardiac compression or 2 minutes compressions. And the second person will be the airway. This person's responsibility will be the opening the airway and using the appropriate adjunct airways. Either it may be OPA, that is oropharyngeal airway, or the nasopharyngeal airway, or if you're well versed and if you're in the hospital setting and if you're able to put the LMA, that's fine. So whatever you have the adjunct airway, you can put it in the initial place. When the anesthetist comes, they can put the definite airway, that is the endotracheal tube. So initially, that this person's responsibility is that assess whether the patient, whether you can do the jaw thrust. If there is no cervical spine injuries, then you can go for the head tilt and chin lift maneuver, and you can use the you open the airway and start giving the rescue breathing. That is, for every 30 compressions, 2 breathing. And if there is the advanced airway, for 15 compressions, 2 breath. But we'll cover that one at later stage in the coming webinars. So compressor's responsibility is giving the compressions, that's 30 compressions. The airway person's responsibility is that opening the airway using the appropriate adjunct airways and giving the 2 breaths after every 30 compressions. Whereas the person who's taking care of the AED or monitor or defibrillator responsibility is that bringing the AED at right time. Because giving the shock at right times increases the survival rate. So this person is, the moment he'll bring the AED, he'll open the AED box and he'll follow all the instructions. And please remember, when you open the AED box, don't get panic. Always will think that, okay, no, I'm going to jump in, I'm the superhero. No, take a step back, relax yourself. The more you are calm and consistent, the better outcome. So what you can, the moment you open the AED box, it gives the instructions. Some of the AED boxes will turn on automatically, and some of the older machines will ask you to turn on, you have to turn on manually. Once you turn on the AED, it will give the direction. Okay, it will tell you next, attach the pads on the bare chest. Okay, attach the pad. Before that, you have to connect the connectors. Connect, attach the pad, wait for the instruction. It takes only few seconds, 3 to 4 seconds only. So don't do anything, just follow the instructions. So once it analyzes the rhythm and it advises you. It will recognize it, whether it's a shockable rhythm or it's a non-shockable rhythm. If it is shockable rhythm, it will advise you to give the shock. When it advises you to give the shock, stay clear and advise all the team members to stay clear, give the shock and continue the CPR. So this is the role of the AED, the person who's taking care of the AED. There is a high chance for the other team members may get this shock. It is a clear role of the person who's taking care of the AED that no one should get, that you have to clear the victim and no one should get the shock except the patient. And if you're in hospital setting and if you're using the defibrillator and the monitor, make sure that monitor is visible to everyone, especially to the you and the team leader. So after every 5 cycles, the compressor and the AED monitor, they can switch the role for effective compressions. So this is the resuscitation triangle. So next one is the timer. So the role of the timer is that this person will keep the accurate record of all the events, what's happening, what are the medications given, when you have given the medication, and is there any interruption in the compressions. So everything will be monitored and communicated, but this person won't be communicating individually to any members. This person directly report to the team member. For example, okay, you are given the compression and next one is the epinephrine is due, adrenaline is due, and this person, okay, next 15 seconds adrenaline is due. So this person will communicate to the team leader, and this is the team leader responsibility to communicate to the rest of the members. There is no multiple communication. There's a closed loop communication. Closed loop communication means, for example, as a team leader, if I'll tell you, okay, give the adrenaline. Okay. Then the person who's giving the medication is, I'm giving the adrenaline. I'm given the adrenaline. That means that whole communication is completed. There is no gap. For example, if I say that, okay, give the adrenaline, that person will say, yes, but I don't know whether it's given or not. So that person has to complete that process. Yes, adrenaline given, fine. So, example, if I'm giving the patient is, if I'm advising the patient, what is it? The person who's taking care of the IV, give the adenosine. Okay, how much adenosine? Okay, I have to clearly say that, okay, give the 12 milligram adenosine and give the flush. So that person who's giving the IV medication, immediately after giving, yes, adenosine given. So that means that communication is completed. The loop is completed. There is no open loop. There is no confusion. So the team leader will be communicating to the rest of the member. The person who's taking care of the IV or IO, that is intravenous or intraosseous. So this person usually will be the ACLS trainer. Preferably, everyone should be who is involving in the hospital setting in CPR or high quality CPR should be the ACLS trainer. And you can see if all the team members are ACLS trainers, they have the better control over the situation. But in outside the hospital, we can't expect. We have to use the manpower whoever is available for the best use. So the person who is taking care of the IV or IO will be the responsible to initiate. That is, he or she will be the inserting the IV line or the intraosseous lines and giving the medications. And this person is responsible for taking the initial blood sample also in the hospital settings. So team leaders should be very constructive. There is no fight in between, because what happens in theory it looks very simple, very idealistic, but when it comes to real situation, this is different. No matter which part of the world, so everybody will be under pressure. There won't be any proper understanding sometimes, and there will be a chance for the communication gap, or somebody may get angry, somebody may shout. So as a team leader, he or she should be calm, consistent. If somebody else is doing the mistake, correct constructively. Don't criticize. That's not a time to criticize. So be constant. And if the one person is not able, for example, if the compressor is not able to compress properly because of the some problems, or if he or she is getting exhausted frequently, change the role as appropriate, but not abruptly. At the end of the day, the patient safety is more important. So this is the role of the team leader. I'll play the video next, and you'll understand how the situation works in a better way.
Rajendra, his audio is not clear.
Okay. Sorry, Mr. Rakesh, can you share this slide from your end, please?
Yeah, you can play. That's good idea.
I think there's a problem with my computer.
I'll do.
Okay.
Rajendra, can you exit from the screen sharing, please?
Oh, sorry. Okay.
Then Rakesh can go.
Yeah, okay.
Is it visible?
Yes, G.
Yes,
yes,
it is. Yeah.
I think in
Now that we know what the team roles are, Let's talk about how these roles can work together in the most efficient way possible. It's important to know not only what to communicate, but also how to communicate with your team, regardless of your role. Use these elements of effective team dynamics to practice good communication in a team. Clear roles and responsibilities.
James and Eric, can you two cycle through chest compressions for the first rounds?
All team members need to know their jobs and responsibilities. The team leader should define these immediately. Knowing your limitations.
You can swap out compressions every 2 minutes or sooner if you get tired.
Team members should be aware of their limitations and ask for assistance early, not when the situation deteriorates. Constructive interventions.
James, you should provide continuous compressions and I'll give a breath every 8 seconds.
Are you sure? I think it's 30 to 2 until we get advanced airway.
You're right, James. Good catch.
A team member or team leader may need to correct actions that are incorrect. It's important to be tactful when delivering this correction to a colleague. Knowledge sharing.
Kayla, can you provide a summary of the action so far?
We've inserted an IV and attached a monitor. We're due to analyze in 20 seconds.
Team leaders should frequently ask for observations from team members about possible oversights to improve team management. Summarizing and reevaluating.
We're a BLS crew. With a 16-year-old male here, witnessed cardiac arrest precisely 3 minutes ago. Has been moved back.
Okay, thank you.
Summarizing information out loud is a good way to maintain an ongoing record of treatment and to reevaluate the team's progress within the algorithm of care. Closed-loop communications.
Aaron, if a shock is indicated, resume compressions while the defib charges.
The team leader should call people by their names when he or she gives an order. Team members should then confirm that they heard and understood the order before letting the team leader know the intervention is complete. Clear messages.
We have an IV.
Now I'm working on IV now.
Well, if you can't find the first fit, try an IO.
Okay.
Use concise and clear language to help prevent misunderstandings, speaking in a tone of voice that is loud enough to understand, but also calm and confident. Mutual respect.
You're right, James. Good catch.
All team members should display mutual respect and a professional attitude to other team members. Because emotions can run high during a resuscitation attempt, it's important that the team leader speaks in a friendly and controlled voice. Debriefing. Debriefing as a team during and after a resuscitation attempt helps individual team members perform better and brings awareness to system strengths and deficiencies. Now that we know what the team roles
this is already covered. Okay, the few more special instructions are the consideration during this COVID pandemic. So a few things, the what we used to practice before the pandemic, it cannot be practiced in this current situation. So one is, there is no mouth-to-mouth breathing, absolutely no breathing, even in your home, in your if it happens to friend, family, that's your personal choice. But comes to the healthcare setting, absolutely no matter what happens, there is no mouth-to-mouth breathing, only the compressions. And and also avoid using the pocket mask pulse, because that won't give you 100% protection, because there are different levels of filtering systems, and the existing pocket mask cannot be won't protect the healthcare providers from the COVID. So no mouth-to-mouth breathing and no pocket mask, and only the chest compressions. If you notice the patient is collapsed, patient no pulse, no respiration, but don't attempt to give the rescue breathing. Protect yourself. As Mr. Rakesh mentioned earlier, scene safety is not only the physical safety. You have to mention infectious. You have to take the infectious precautions also as appropriate. So if you see again, a patient or the victim, no pulse, no respiration, give only the cardiac compression until the patient transferred to the relevant department. Next slide, please. So the whole thing can become, what are the techniques we mentioned here? Oh, sorry, 1 second. Rakesh, are you sharing? Sorry, something. Okay. The basic life support techniques or the what in what order you have to follow these techniques. That is, we know that airway, breathing, circulation is required. But if the patient is a trauma patient, then we are not going for the airway first. We are not going to the breathing. We are going to the circulation. So just to be mindful here, I'm covering the two things. One is a patient who collapsed because of the cardiac cause, or the patient collapsed or had a cardiac arrest because of the trauma. If there are two sequences we have to follow. One is if the patient collapsed right in front of you, or if you found the patient collapsed, no pulse, no respiration. So just to check for the airway, assess the patient, assess the response, open the airway. But important, you have to give the compression first. But assessment includes the airway, breathing, circulation. Once you have done that one, the sequence of the cardiac compression, BLS includes the CAB, that is C for compression, airway, breathing. So this is the sequence you have to follow. But if the patient is involved in a trauma and you are seeing that there is a massive blood loss is taking place, there is some arteries ruptured. So the first priority is that you know that what is the cause for the collapse. So priority is that stop the bleeding. That is, again, we will be using this CCA, that is C CAB. So what happens is that circulation, C stands for circulation, stop the bleeding, okay, go for the compression, airway, breathing. If you know the definitive cause for the cardiac arrest, deal with that one first. So if for example, because the cause for the cardiac arrest is hypovolemia because of the severe bleeding, which is happening right in front of you, apply the pressure or stop the bleeding as quickly as possible, and go for the compression, go for the airway, go for the breathing. Next slide, please. So this is the most important slide, and this is the last slide. So please give the attention, and whatever the questions are coming, everything will be based on this one only now. So, okay, can I request all the members, please, can you mute your mics, please? Yeah. Okay. So when you see the patient who is unresponsive, so before reaching the patient, before approaching the patient, make sure that, sorry, 1 second, I'll share the screen. Rakesh, is it okay to stop this sharing screen, please? I'll share it from my end. Okay, so first one is verify the scene. So once the scene is safe, then go near to the patient. Look for the responsiveness. Hey, hello, are you okay? Are you okay? Tap the patient. And if the victim is unresponsive, the first priority is that don't start the compression. Look for the help. The quicker you look for the help, better the patient outcome. So you don't know whether the pulse is present or not. You don't know whether the patient is breathing or not. That is secondary. The primary is that once the patient is unresponsive, end of the story, call for help. You can't, or I can't alone manage the patient. So once the patient is, if you found the patient is unresponsive, shout for the help. And if nobody is there nearby to you, so preferably use the mobile and call the emergency service. So activate the emergency response system via mobile device if applicable, appropriate. And if you don't have, olden days, whatever the technology you have, that is the landline. Going to the landline, giving number, dialing and everything, it takes time. So if you have a mobile, or if a bystander, if anybody have the mobile, use the mobile and activate the emergency response system. And get the AED and the emergency equipment. Preferably, if the second person, if two persons are there, you stay with the patient and ask the second person, activate the emergency response system and request the person to get the AED as quickly as possible. So once this process is completed, you have to assess the patient for minimum 5 seconds, but not more than 10 seconds. So after your assessment, if you determine the patient is having the normal breathing and the pulse, but is collapsed, so stay with the patient Monitor the patient regularly till the emergency response arrives or emergency team arrives. So don't assume, okay, patient is having the pulse, patient is breathing, but patient is unresponsive. Don't assume that that state will continue. Patient may lose heartbeat may stop. Patient breathing may stop. So we don't know what is the cause for the collapse. So stay with the patient, but anticipate the worst situation. But if the patient have no normal breathing, but he has a pulse, that is, pulse is present when you check the carotid pulse, but patient is not breathing. So in that case, open the, that is, you have to follow this sequence, that is, provide the rescue breathing. How many breaths? 1 breath for every 5 to 6 seconds. That is approximately 10 to 12 breaths per minute. Then at this stage, if no emergency activation is not activated, please activate at this stage. Ideally, we have to initiate at this stage, but if it's not done, still you have a time, activate the emergency response after 2 minutes of your initial intervention. Then continue the rescue breath, check for the pulse for every 2 minutes. If no pulse, come for here. If there is a pulse, continue the rescue breath. That is 1 breath for every 5 to 6 seconds. That is per minute, 10 to 12 breaths. So look for, if at this stage, after 10 seconds, if there is no pulse, no breathing, then go for the CPR stage. So patient may jump from this one to this stage or this stage to this stage. So see, when you determine this patient needs the CPR, begin the cycles of CPR, that is 30 compressions and 2 breaths. And use the AED as soon as possible. As I mentioned, early use of the AED improves the patient outcome. The mortality rate will be lower compared to the without AED, because dealing with the abnormal electrical impulses and terminating them as quickly as possible and bringing back to the normal sinus rhythm saves the patient's life. So at this stage, if the AED arrives, attach the AED and allow the AED to analyze the rhythm, whether it's a shockable rhythm or non-shockable rhythm. For example, shockable ventricular fibrillation. If it's a non-shockable pulseless electrical activity. So in case of pulseless electrical activity, no shock, absolutely no shock, only the CPR, high quality CPR can save the patient. So if the shockable rhythm, give 1 shock. So immediately after the shock, don't wait for the response, just commence the CPR. And that should start with this compression, no rescue breath, straight back to chest and start the compression. That is 1 shock, resume CPR immediately for 2 minutes. And after 2 minutes, again, your AED will prompt you, okay, stop analyzing the patient. So at that time, clear the patient, don't touch the patient, allow the AED to analyze the rhythm, and it will prompt you again whether the shock is required or continue the CPR. And if no shock are advisable, continue the CPR. So in both cases, whether the shockable or non-shockable, follow the prompts and wait for the emergency medical system service to come near to you and rescue the patient. And if it is within the hospital setting, continue the CPR till the whole team comes to you and they will take over. Okay, so this is the end of the presentation. Somebody has mentioned in the chat box regarding the CPR for the pregnant lady. Because of the time restriction, we won't be able to cover, but I'll post in the group, in the clinical group, I'll post even including the algorithm from the AHA. I'll post it in the group. That's easy to follow, simple. And if you have any queries, please post the questions in the our WhatsApp group, and I'll get back to you as soon as possible. So here I'm going to post.
Rajendra, are you going for question and answer now or after this quiz?
I think we'll go for question and answer, then I'll post the questions in the chat.
No, Rajendra, go ahead and post the questions. We can simultaneously answer the questions as well.
I think that's...
No, but because they have only 15 minutes for 20 questions, so everyone will be focused on the question.
No, it's okay. They can answer. Those who want to ask questions, they can ask questions.
No, what happens is that if they want to attempt the question, they won't be able to. What we'll do, we'll take 5 minutes question and answer session. Then we'll give 15 minutes, and after 15 minutes, the link will be closed automatically. So no need for us to wait for them.
Okay.
So they can exit, and we can finish the webinar.
Okay.
Can we take the questions which are in our chat box? Swami?
Yeah, we can take questions. Ashwini, you had some questions. Ashwini Bhosle. Jasmine, you had some questions. You raised your hand earlier. How to tackle with the pacemaker?
The pacemaker, if patient is with a pacemaker, no need to worry. Just keep your the pad of AED away from the this pacemaker. That's all.
Yeah. Okay. Thank you, Rakesh. Whatever. Check the airway with clenched mouth. Kanchan, do you want to unmute yourself and ask the question rather than chatting?
Rajendra, can you close the screen sharing, please?
Okay, that's what I was trying to look here. Sorry.
Thank you.
Has anyone else got any questions?
Nilima Raj has asked about the 2020 guidelines of AHA for CPR. Whatever we have presented, we followed recent guideline of AHA. So the sequences are CAB, which already discussed by Mr. Rajendra, and then component of CPR, CAB we have discussed, and about the chest compression, it should be like 2 inch or 5 centimeter minimum. So 5 to 7 centimeter it is a range. So if it is same like 5 to 6, 7 centimeter or 2 inch, both are equal. Then one question was about the pregnant. There is no change. I think Mr. Rajendra will answer in the chat box. But one thing I'll tell you, if the patient is having is a pregnant woman, no need to worry. Just give chest compression over the chest. You can place your hand a little above from in the sternum. That's all.
Can I request, you are all unable to unmute yourself. Can I request you to type the question in chat box, please? That will be a quicker way to answer your questions. Thank you.
Kanchan, you can talk now. I've unmuted you.
When rib fracture, continue CPR. Yes, you can continue, but just see that you're not damaging. But what happens like a new person in a healthcare system, or student or SR, JR or our intern, they give CPR and most probably a good quality or there is a breakage in the rib also. So no need to worry. If you have to shift the patient to the healthcare center, and then in the healthcare center, all the things has to be taken care because patient has to go to the OR. If patient is had this rib fracture, there may be possibility that puncture of lung. Then accordingly, we have to treat and plan for.
So how long CPR can be continued?
I have given answer about this building itself.
Yes.
Until the help arrive or you got exhausted. Now, if I am giving CPR, I am giving since last 20 minutes or 30 minutes. I got exhausted. Now I'm totally tired, so I can stop CPR.
And also, there's one, I think she may be asking in the clinical setting, how long we have to continue the CPR. Am I right?
It could be.
No, it sounds right.
Yeah. So then if it is a community setting, it's different. But within the hospital, it's all depend upon the patient's comorbidities. How long it took patient to transfer from the community to the hospital. Imagine if you are there in the community and you are doing the CPR for the 30, half an hour or 1 hour, and you are bringing the patient after 1 hour, and the patient has no pulse for the last half an hour, 1 hour. That means the patient is in the pulseless electrical activity stage, or patient already the stage of the reverse prognosis already is gone bad. So you have to take a decision. You can't continue CPR for another 1 hour, which is of no use. So you have to consider how long the patient is having the witnessed collapse, how long is the patient is having unwitnessed collapse, how long CPR has been done, how many shots has been given, and what are the medications has been given. So there is no straightforward answer. It's all depends upon the individual cases. So ideally, we say that minimum 5 cycles we have to 20 minutes CPR, advanced CPR, that is with the ACLS, we have to do to get the outcome. But again, there is no clear answer for that one. If the 90-year-old or 100-year-old patients comes with a collapse and have multiple comorbidities, so we can't continue CPR for longer time. So we have to consider that one. Or if the younger, only 20-year-old patient comes, and there is high probability that, yes, we have to do something else. Yes, we will do, even beyond the limitations, we'll go and we'll do. At the end of the day, it's a team leader decision, and it's a collective decision of the team, all the 6 members who are doing the CPR. So honestly telling, there is no one can give the clear answer how long we have to continue the CPR in hospital setting. So we have to consider based on the patient comorbidities and the clinical scenario, what's happening at this stage.
Yeah, rightly said. And there's another question from the Nilima Raj about the Good Samaritan law. Yes, now Government of India, and there's a law which protects the bystanders to involve in a legal issues. So if anybody, like anyone, a layman also can help a person for their health, their life safety. They can transport the patient to the hospital, and also we are working to the save of the patient or life of person. So definitely that law is in favor of for the healthcare worker as well as for the layman also.
And also the same law will protect the general public also. There is no, even though it's a medical legal case, no further questions will be asked in the in the police stations, and that person won't be officially involved in the police case, even if it is an accident, and if you see the patient, even there's a road crash, and if you have seen the patient and he's injured very badly, you can transfer the patient, but absolutely you're not involved in the police case, and you are well protected from this new law. That is on paper, but that is what we understand. But don't quote my words, how the system works.
Rajendra, can you go for questions? So after the questions, we can take quiz. I mean, you can take any questions after this one. Yeah.
Okay. How can we a decision in the DNR, or is there any criteria for DNR? Absolutely, the DNR criteria can be either the patient can decide before patient get worse. Patient can be in the hospital or nursing home or home. So I can decide now itself, okay, if I had a cardiac arrest tomorrow, I don't want any kind of resuscitation. So I can decide, and I can communicate and to my GP, and it will be in my file. Or a family member will be knowing, patient, for example, patient will be telling to the family member, no, if anything happens to me, don't take me to the hospital. Even if you're taking me to the hospital, I don't want any resuscitation, CPR on me. So the family can communicate. So, or if the patient is inpatient in the hospital and patient can directly communicate to the healthcare providers, I don't want this one. That's a patient decision. Okay, so that's one thing. In certain conditions, the medical consultant can take a decision. Patient may be very confused and have multiple comorbidities, and there is no clinical prognosis if you do the CPR on the patient before cardiac arrest happens. So there will be some decision will be made before. Yes, on patient, clinical consultant also have authority to make the DNR, but there should be clear guidelines as well as the explanation why the consultant is taking the such decision.
I think Rajendra,
in case of there's one more question.
Rajendra, sorry, go for quiz now. We can take the question afterwards, please.
Okay, one last question. In case of spinal injury, jaw thrust technique. Yeah, that is true. In case of suspected, imagine if the patient fall from the ladder, fall from the building. Even the patient looks normal, patient is collapsed, don't assume there is no spinal cord injury. Always expect spinal cord injury, especially the cervical collar. So in that, don't do the head tilt and chin lift maneuver, only the jaw thrust maneuver for the precaution. Okay, so I'm going to post the link for the quiz. It's having a 20 questions and the 15 minutes. Okay, and it's in the Google form. So please give the fill in your right email ID and your full name, because this, if you fill the wrong email ID, it will bounce back. You won't be getting the we won't be able to get the feedback properly. So you won't be getting the certificate. So your right name, full name, and the email ID is essential to get the certificate, and 90% marks is required. I wish you all best of luck with the quiz. Here we go. So you can click on the link which is provided in the chat box.
Can you share on the YouTube as well, please?
Yes, and please can you post it in the YouTube? I didn't open the YouTube from my end. Same link.
Okay.
Rajendra,
we have an option now. Shall we wait for 15 minutes?
No, I think we should wind up the session and wait for the participants to respond.
Okay.
Because there are some staffs who are waiting to go back to work and all that. So
I have posted in the YouTube as well anyway. Okay.
Okay.
I would like to say a huge thank you to Dr. Rakesh Sharma for such a valuable session on behalf of GINA and on behalf of the participants. Mr. Rakesh ji, thank you so much for the informative session that you've done with us. I hope this has been helpful to all the participants, and hopefully you'll be able to adapt these scenarios. I'm sure most of you have done your BLS sessions already, and this is probably a refreshment for all of you, refresher. Hopefully there are some take-home messages for you to implement in practice, and you have seen some new equipments as well that you can adapt in your new clinical settings. And I wish you all very best with the quiz and with the further training sessions. Thank you all once again.
Recording stopped.
And also, I would like to say special thanks to Mr. Karthik Vasista. So he's the special person. I can say that one in all our activities, what we carried out in the COVID crisis management team. So he's the backbone with all our IT support. A special thanks to Mr. Karthik. Thank you.
Yeah, Karthik has provided us the IT support. Karthik, I really appreciate you.